What is the answer to the problem of venous disease in the UK then, would you say? How are we going to expand treatment? I did admire were the presentations by the Society for Vascular Nurses and the nurse specialists who were telling us about the dreadful burden of venous disease causing ulceration in the United Kingdom. The fact that the number of people with an active leg ulcer in the United Kingdom is growing, that access to treatment for leg ulceration seems to be getting worse, that despite numerous trials, the EVRA trial in particular, changes in guidance from the Venous Forum and the Vascular Society, access to treatment for leg ulcers seems to be getting worse. How are we going to sort that out, do you think, Bruce?
Please read the British Medical Journal editorial that I had published with Dan Carradine in January of this year, entitled Silent Crisis of Venous Care in the UK, which addresses a lot of this. And I mean, just taking just a couple of themes. Firstly, the whole business of the primary care in the community. I think there's a desperate need for better education in primary care, because many GPs don't recognise the early signs of venous skin change. Many actually don't recognise the later signs of venous skin change. And so that's important. Once patients have developed ulcers, then the provision of really good, slick pathways is important. At the moment, those are present in some localities, but in others, there are not good pathways, but first of all into nursing care in the community, and then seamlessly into vascular care in secondary care to deal with varicose veins. So all of that's important. Education in primary care, the provision of really good pathways, and the recognition in secondary care of the importance of really prompt treatment of varicose veins when ulcers or pre-ulcer states exist. I mean, one of the problems, Haroon, and this gets into very, very controversial and sensitive areas, is that, all of this is provided by vascular surgeons, basically, within the National Health Service. And it's not unfair to say that the predominance of vascular surgeons are interested in arterial disease. And given a limited amount of time, as people increasingly have on their programs, both for training and for practice, they want to fix aortas and they want to do other exciting bits of arterial disease. And the venous disease very frequently gets given second place, both in training and in NHS practice. And I mean, some of the suggestions that I've made is that I think each vascular unit ought to have a venous lead, and that person shouldn't just be a sort of Buggins turn there in name, but actually a potent figure on the unit who presses the management of venous disease. And so I think having someone who is the lead on venous disease in each vascular unit, I think that all new vascular surgeons certainly ought to have some venous sessions on their program. I think so that everybody is dealing with it. And I think also, although this is another big matter for debate, when it gets onto the more complex deep venous disease, then we should be increasingly looking at developing more centres with real experience in the complex treatment of deep venous disease. So those are all things that I think are moves that we could make to improve the delivery of care to patients.
Do you think one of the problems is that it's regarded as a vascular disease that needs referral to a vascular unit?
I think that with the present structure, yes. I think I may be misinterpreting you, but I think you're starting to enter into the argument of should we have a specialty called phlebology?
Because Not necessarily. I think maybe we could recognise that venous leg ulcers are mainly due to superficial venous reflux. I think one of the problems is that venous leg ulcers get referred to a vascular unit, and I wonder whether we should agree that most cases of venous leg ulceration are due to superficial venous reflux, and that most superficial venous reflux can be dealt with very well, very promptly, at low cost, and without necessarily being admitted to hospital by ultrasound-guided foam sclerotherapy.
I think without any doubt that is the simplest and cheapest option. Whether it's the most cost-effective option is another matter, but certainly it's the least expensive option, and certainly it's an approach that many places are taking. And I completely understand that within the limitations of the NHS. But if you then look at any argument we might have about the long-term results on the foam sclerotherapy in terms of venous ablation, we know that the results are not as good for long-term ablation or even short-term ablation of main venous trunks. It's a very simple thing to do. It's repeatable, and I can well understand why that approach would be adopted in a cost-strapped system. Whether it's the best and whether it's the most cost-effective is something that the jury's out.
Well, here's a counter-argument, Bruce. At the moment, people are getting nothing.
Oh, well, that's obviously quite wrong. That's quite wrong.
No, it's not only wrong, it's getting worse. I mean, the majority of people are getting no treatment for their leg ulcers, and the number of people with an active leg ulcer in the United Kingdom is increasing. As an aside, I would like to know why you say that foam sclerotherapy is inferior to endothermal or glue. But even if I agree that, at the moment, people are getting nothing. Shouldn't they get an effective, safe treatment that is simple, cheap, and can be done by people with minimal training, not vascular surgeons, not vascular trainees, nurses, technicians, minimal training, inject foam around the ulcer, get the ulcer at least healed, and then sort out the mid-term, long-term problems?
Well, I think you've introduced a lot of things there. I mean, the first thing to say to you is, I mean, in terms of what I think, my thoughts are in the Royal Society of Medicine's guidelines, which were published 2 or 3 years ago, about people with venous ulcers, saying exactly what you've said. They should be referred, they should be getting investigation and treatment within a very short period of time. So, I mean, that's very clear. The Venous Forum has produced guidance on that for national use. So that's the first thing. The second thing is, the whole business of who treats patients and the business of whether this should be fully trained doctors, whether it should be nurses or technologists, is a very live debate that has caused a lot of ill feeling on both sides in a way which I think has been unhelpful and counterproductive. There are fears on the side of many vascular surgeons that it would interfere with training. Or what about governance? What about if complications occur? There is equally the whole business of the Society for Vascular Nurses, who produced a very, very thorough document about training, about governance, about who should do this. And then there are instances which have been precipitated this, of nurses in particular places who've run very, very successful programs for treatment. So all those things are going on. It's unfortunate that there are people on both sides of the debate who have very strong feelings and prejudices. I mean, what I would foresee happening, I think it's almost inevitable that there will be more treatments administered by non-vascular surgeons. I think that's inevitable. But I think this isn't something you can sort of legislate for or tell people what to do. I think it's going to be a matter of evolution, because as has happened in the places who have nurses giving these treatments, they happen to have had somebody who's jolly good, very keen, in the right place at the right time, who they've trained and who's set up a very successful system. So I think it's very person dependent. And I think that is likely to happen, in different localities. But I don't think that it's something that we should be, if you like, legislating for. I think it's something that should evolve, but should evolve with very careful attention to the kind of considerations that the Society of Vascular Nurses have given in the document they've produced about training. So I think it is horses for courses, and I don't think that there is any one-size-fits-all for that particular issue.
Interesting, isn't it? Well, let me suggest to you that the idea that we should not legislate, or at least not take a leadership role and really push this, the idea that we should let it evolve might just be kicking this into the long grass. This is not going to happen unless people of seniority in senior, well-regarded organizations like the Venous Forum actually stick their neck out and say, this is what should happen, rather than giving guidance and guidelines. What do you think, Bruce?
I think the answer is it's a live issue that's going to keep appearing. This is an issue that's not going to go away. It's going to keep appearing on the meeting schedules of the Venous Forum as well as elsewhere, quite rightly so that people will keep an eye on what is going on, how it's all evolving. But this is not something that's going to be kicked into the long grass. It's going to be a matter of live discussion for the foreseeable future, no doubt.
Okay.